52-year-old man presents following collapse. He was previously fit and well, describing only a relatively recent history of dull back pain. Initial CT scan of the head reveals a 1.5 cm hyperdense mass at the corticomedullary junction of the right cerebral hemisphere. The mass shows surrounding edema which exceeds the volume of the lesion. There is strong lesional enhancement following contrast injection. What is the most likely diagnosis and subsequent management? A. Glioblastoma multiforme with subsequent MRI of the brain. B. Prostatic cancer metastasis. Hemorrhage. Ref. Dannert P. 320. 21. D. Renal cell metastasis with subsequent CT staging. Brain metastases account for approximately a third of all intracranial tumors and are the most common intracranial neoplasm. They characteristically occur at the corticomedullary junction of the brain and have surrounding edema that typically exceeds the tumor volume. Multiple lesions are present in approximately 2/3 of cases and should be searched for with administration of intravenous contrast. Most are hypodense on CT unless hemorrhagic or hypercellular, hence the lesion in this case is hemorrhagic. This lends itself to a differential of primary neoplasms which includes melanoma, renal cell carcinoma, thyroid carcinoma, bronchogenic carcinoma, and breast carcinoma. The history of back pain also suggests bone metastases. Glioblastoma multiforme usually appears as an irregular, heterogeneous, low-density mass. Abscesses typically demonstrate ring enhancement post-contrast and may show loculation and specules of gas. The patient's history describes collapse rather than headache or confusion following a fall, which moves the differential away from traumatic contusion. Although prostate cancer typically metastasizes to the vertebrae, it is an uncommon primary site for brain metastases, especially as the lesion described is hemorrhagic. Ref. Dannert P. 309. 22. B. Hyperintense on DW MRI and low ADC values. Diffusion-weighted imaging is dependent on the motion of water molecules. D. Renal cell metastasis with subsequent CT staging. E. Brain abscess with subsequent intravenous antibiotics. 22. Which of the following best describes the appearance of an acute ischemic infarct of the brain? 131. Module 6 Central nervous and head and neck. A. Hypointense on diffusion weighted, DW, MRI, and low apparent diffusion coefficient, ADC, values. B. Hyperintense on DW MRI and low ADC values. C. Hypointense on DW MRI and high ADC values. D. Hyperintense on DW MRI and high ADC values. E. Isointense on DW MRI and low ADC. Molecules and provides information on tissue integrity. It is thought that interruption of cerebral blood flow results in rapid breakdown of energy metabolism and ion exchange pumps. This causes a shift of water from the extracellular compartment into the intracellular compartment, giving cytotoxic oedema. This produces the hyperintensity on DW MR images. ADC values tend to be low within hours of stroke and continue to decline for the next few days. They remain reduced through the first 4 days and then show pseudo-normalization between 4 and 10 days. After 10 days the ADC tends to rise. Hyperintensity on diffusion-weighted, DW, MRI, and low ADC values are not pathognomonic of acute infarction, but sensitivities and specificities of 94% and 100% have been reported. Other conditions including hemorrhage, abscesses, lymphoma, and Creutzfeldt-Jakob disease have been described. 146. Module 6 Central nervous and head and neck answers. Ref. Atlas P. 939. Stadnik TW ETA. D. Hyperintense on DW MRI and high ADC values. E. Isointense on DW MRI. MRI and low ADC values. 23. A 30-year-old female complains of increasing headaches, episodic vomiting and drowsiness. Fundoscopy reveals papilloedema. Non-contrast CT of the head demonstrates hydrocephalus and a globular lesion within the lateral ventricle. There are several small internal foci of calcification. Mr. shows the mass to be attached to the septum pallidum. It is iso-intense to gray matter on T1 and T2. It densely enhances after intravenous gadolinium. What is the most likely diagnosis? A. Ependymoma B, subependymoma C, central neurocytoma D, heterotopic gray matter E, meningioma. On diffusion-weighted Mr. images. Radiographics 2003, 23, E7. 23, C. Central neurocytoma is an intraventricular, grade 2 neuroepithelial tumor with neuronal differentiation. This rare neoplasm tends to occur between the ages of 20-40 years. Patients typically present with symptoms and signs of hydrocephalus. Imaging typically demonstrates a globular lesion attached to the septum pellucidum. Calcification is considered characteristic, however it may be absent in approximately half the cases. On MRI, the lesions are usually iso-intense to gray matter and show dense contrast enhancement. Enhancement. It is extremely uncommon to see peritumoral edema. Heterotopic gray matter should not enhance, contain calcium, nor be attached to the septum pellucidum. Intraventricular meningiomas are typically located at the trigone. Subependymomas are hyperintense to gray matter on T2, while ependymomas tend to be heterogeneous, childhood lesions that occur in and around the fourth ventricle. D. Heterotopic gray matter E. Meningioma. 24, which is the preferred sequence to use when attempting to identify posterior fossa lesions on MRI in patients with multiple sclerosis. A. T1, weighted spin echo B, T2, weighted spin echo C, flare D, gradient. Refs, Atlas P, 627, Dannard P, 302. 24, B, T2, weighted spin echo multiple sclerotic plagues can be located anywhere in the central nervous system, but typically they form at the junction of the cortex, and white matter and periventricularly. Flare is particularly good at locating periventricular lesions as CSF signal is suppressed. In the posterior fossa, however, flare detects fewer lesions than T2, weighted spin echo. Ref, Granger and Allison P, 1300. E. Proton density. 25, a 35-year-old man attends the accident and emergency department complaining of episodic lower back pain radiating down the legs. History and clinical examination also suggest pelvic sphincter dysfunction. MRI shows a spinal cord mass located at the conus medullaris. The mass is isointense on T1 and hyperintense on T2. It demonstrates contrast enhancement. The most likely diagnosis is A. Astrocytoma. D. Myxopapillary ependymoma. This is a variant of ependymoma, and is the most common neoplasm of the conus medullaris. It originates from ependymal glia of the phylum Terminale. Average age at presentation is 35 years, and it is more common in men. T1, weighted imaging shows an isointense, or occasionally hyperintense, due to the mucin content, mass. It is hyperintense on T2, and almost always shows enhancement post-contrast. Intradural lipomas are hyperintense on T1, weighted imaging, but they should not enhance. They also tend to occur in younger individuals and usually have an associated, clinically apparent lumbosacral mass. Hemangioblastoma can also demonstrate high signal on T1, but is also highly vascular, can show signal voids, and approximately half of them will have an intratumoral cystic component. Gangliogliomas are much more common at the cervical and thoracic. E. Ganglioglioma. 26. A 13-year-old boy is investigated for chronic headache and visual disturbance. CT shows a well-defined mass in the left middle cranial fossa. It is isodense to CSF. There are no calcifications, no surrounding edema, and no contrast enhancement. There is erosion of the underlying calvarium. You suspect this is an arachnoid cyst, but your consultant suggests the possibility of an epidermoid cyst. What MR imaging sequence would best differentiate the 26. A. Diffusion-weighted MR imaging epidermoid and arachnoid cysts can look very similar on CT. 27. A 3-year-old girl undergoes a CT scan of her head following trauma. No acute pathology is demonstrated, but there is basal ganglia calcification. Which of the following can be excluded as a cause of the calcification? A. Down syndrome. B. Neurofibromatosis. C. Birth hypoxia. D. Wilson disease. E. Congenital rubella. 28. The husband of a 30. D. Wilson disease. Causes of basal ganglia calcification include physiological aging, infection/inflammatory, torch, TB, cysticercosis, measles, chickenpox, pertussis, Coxsackie virus, AIDS, SLE. Toxins, lead, carbon monoxide, birth anoxia/hypoxia, chemotherapy/radiotherapy, nephrotic syndrome. Congenital, Cockaynes, Fahrenheit's and Down syndromes, neurofibromatosis, tuberous sclerosis, methemoglobinopathy. Endocrine, hypothyroidism, hypoparathyroidism, pseudohypoparathyroidism, pseudohypoparathyroidism, hyperparathyroidism. Metabolic, Lee disease, mitochondrial cytopathies. Trauma, infarction. Ref. 28. The husband of a 33-year-old woman takes her to the local accident and emergency department, stating that she is becoming acutely confused and is not her normal self. Her past medical history is unremarkable apart from a flu-type illness a few days earlier. Her GCS is 13, E4, V3, M6. Initial non-contrast enhanced CT of the brain shows low density change within the left temporal lobe. MRI demonstrates abnormal low signal on T1 and high signal on T2 within the left temporal cortex. The insula is involved, but there is sparing of the putamen. There is mild mass effect with partial effacement of the lateral ventricles. What is the most likely diagnosis? A. Herpes simplex encephalitis. B. Low-grade glioma. C. Brain abscess. D. Post-viral leukoencephalopathy. E. Dural sinus thrombosis leading to 28a. Herpes simplex encephalitis, house. There are two main types of herpes simplex virus, HSV type I and HSV type 2. Type I, oral herpes, tends to affect older infants, children and adults, whereas type 2, genital herpes, is the usual cause of house in neonates. House is a necrotizing meningoencephalitis which has a predilection for the limbic system, temporal lobes, insula, cingulate gyri. Characteristically, there are poorly defined areas of low attenuation in one or both temporal lobes/limbic system on unenhanced CT, low signal on T1, gyral edema, and high signal on T2. The T2 high signal typically spares the putamen and forms a sharply defined border. Changes may initially appear unilateral, but contralateral disease invariably follows. This sequential bilaterality is characteristic of house. Hemorrhage is typically a late finding. Mortality ranges from 30% to 70%, but is reduced with early antiviral therapy. (29) A 58-year-old man presents with impaired vision and intractable headaches. He has a past history of recurrent sinusitis. Examination reveals left-sided proptoses and a palpable mass in the supramedial aspect of the orbit. CT demonstrates a soft tissue mass causing expansion and erosion of the left frontal sinus. Sinus. There is peripheral enhancement post-contrast injection. The next radiological step should be A. Referral to an appropriate clinician. You have made a confident diagnosis of a benign etiology. B. MRI of the head. (29) A. Referral to an appropriate clinician. You have made a confident diagnosis of a benign etiology. This is almost certainly a mucocele. Mucoceles represent the end stage of a chronically obstructed sinus. They most commonly affect the frontal sinus, 60%, with ethmoid 30%, maxillary 10%, and sphenoid, rare, following respectively. Patients present with symptoms as described in the question. Increased intrasinus pressure results in expansion and erosion of the sinus walls. There may be a surrounding zone of bone sclerosis. Contrast injection typically reveals rim enhancement, which helps to differentiate from the more solid enhancement pattern of neoplasms. Rep. (30) Regarding radionuclide imaging of thyroid cancers. Cancers, which radiological finding best fits the diagnosis. A. Usually concentrates radioiodine follicular carcinoma. B. Usually concentrates pertechnetate papillary carcinoma. C. Usually concentrates pertechnetate and radioiodine papillary carcinoma. D. No radioiodine or pertechnetate uptake but frequently concentrates thallium, 201 medullary carcinoma E. No radioiodine or pertechnetate uptake but frequently concentrates thallium, 201 anaplastic carcinoma. D. No radioiodine or pertechnetate uptake but frequently concentrates thallium 200 and 1 medullary carcinoma. Types of thyroid carcinoma, in order of worsening prognosis, are papillary, papillary, follicular, medullary, and anaplastic. Papillary tumors usually concentrate radioiodine, follicular tumors concentrate pertechnetate, but fail to accumulate radioiodine, and anaplastic tumors show no radioiodine uptake. A patient known to have AIDS presents with increasing malaise and confusion. Confusion. CT brain shows multiple cerebral hypoattenuating nodular lesions with varying degrees of 133. Module 6 central nervous and head and neck. Surrounding edema and mass effect. There is lesional enhancement post-contrast administration. Which of the following conditions can be confidently removed from the differential diagnosis? A. Tuberculosis. B. Pyogenic abscesses. C. Progressive multifocal leuko. C. Progressive multifocal leukoencephalopathy. Leukoencephalopathy. Progressive multifocal leukoencephalopathy affects about 4% of AIDS patients and is caused by reactivation of ubiquitous JC papovivirus. This causes lysis of oligodendrocytes resulting in demyelination. CT shows single or multiple hypoattenuating white matter lesions without edema/mass effect. There may also be gray matter lesions in the thalamus/basal ganglia from involvement of traversing white matter tracts. The majority of patients show mild cortical atrophy. The condition carries a poor prognosis with death within 2 to 5 months. All the other conditions listed will have various amounts of surrounding edema/mass effect and enhance post-contrast. Toxoplasmosis is the most common cerebral mass lesion in AIDS and is 2 or 3 times more frequent than lymphoma, the second most common cause of a CNS mass in AIDS. Multiple lesions suggest toxoplasmosis over lymphoma, however when there is a solitary lesion the probability of lymphoma is at least equal to that of toxoplasmosis. Which of the following neurological imaging findings would offer a clear differential diagnosis between tuberous sclerosis and neurofibromatosis type I? A. Basal ganglia calcification. B. Optic. D. Enhancing heterotopic gray matter. All of the other features may be found in either condition. Giant cell astrocytomas located in the region of the foramen of Monro in tuberous sclerosis may degenerate into high-grade astrocytomas. Cortical tubers show as multiple nodules which are hyperintense on T2/FLAIR imaging. CNS hamartomas, occurring in up to 75–90% of NF1, also display these characteristics. They are often termed unidentified bright objects. 33. A 65-year-old woman is investigated for enophthalmos and headache. She is cachaic, anemic, and you suspect a metastatic process. CT head demonstrates an infiltrative retrobulbar mass. What is the most likely site of primary disease? A. Breast. B. Lung. C. Renal. D. Melanoma. E. Ovarian. (33) A. Breast. Most retrobulbar metastases are extraconal, outside the muscle cone. Neuroblastoma and Ewing sarcoma are the most common in children and produce smooth extraconal masses related to the posterior lateral wall of the orbit. In adults, an infiltrative retrobulbar mass and enophthalmos is characteristic of serous carcinoma of the breast, invasive ductal carcinoma. Enophthalmia is also considered to be one of the earliest signs of metastatic breast cancer. Ref. Granger and Al. (34) A 40-year-old man with no previous medical history or medication attends the accident and emergency department. He was the driver of a car that was involved in a car-on-car vehicle collision at approximately 40 miles per hour. He was wearing a seatbelt and his airbag deployed appropriately. According to NICE guidelines for head injury, which one of the following criteria alone does not warrant an acute head CT scan? A. GCS 15, when he was assessed in the emergency department 2 hours after the accident. B. Hemotympanum. C. Amnesia of events 30 minutes after impact. D. Seizure following the accident. E. More than 34. C. Amnesia. Ref. Granger and Allison P. 1406. Ref. Granger and Allison P. 1406. 34. C. Amnesia of events 30 minutes after impact. NICE defines head injury as any trauma to the head, other than superficial injuries to the face. All of the other criteria listed are requisites for an acute head CT scan. Hemotympanum implies a basal skull fracture, which should be investigated by CT. Amnesia of events greater than 30 minutes before impact would require an acute head CT. Any amnesia or loss of 149. Module 6 Central Nervous and Head and Neck answers. Consciousness. Since the injury requires a CT scan if the patient is equal to or older than 65 years, has a coagulopathy, including warfarin treatment, or if there is a history of dangerous mechanism of injury, which is listed as pedestrian or cyclist struck by a motor vehicle. Occupant ejected from a motor vehicle. Fall from over 1 meter or 5 stairs. Ref. National Institute for Health and Clinical Excellence. Guidelines for the Management of Head Injury. September 2007, http E. More than one episode of vomiting following the accident. 35. A 48-year-old woman presents with symptoms of hyperparathyroidism. Radionuclide and ultrasound imaging suggest the cause is a solitary parathyroid adenoma. The surgeon requests further localization with MRI prior to surgery. Which imaging sequence and plane would you choose as the most sensitive for detection of the adenoma? A. T1 weighted in the axial plane. B. T2 of head injury. September 2007. http://guidance.nice.org.uk/cg56 http://guidance.nice.org.uk/cg56 35. D. T2 fat suppressed in the axial plane. Ref. Ahuja at ETAL imaging for primary hyperparathyroidism. Clin Radiol 2004. (36) A 30-year-old man presents with an orbital frontal headache and visual disturbance. CT head shows a large mass arising from the region of the spheno-occiput and extending into the pontine cistern and towards the hypothalamus. The mass contains amorphous calcification and is seen to cause bone destruction. There is no reactive bone sclerosis. On MRI, the mass exhibits mixed heterogeneous signal and a soap bubble appearance. The solid components show marked contrast enhancement. What is the most likely diagnosis? A. Meningioma. B. Metastasis. C. Chordoma. D. Plasmacytoma. E. Sphenoid sinus cyst. 967-976. 36. C. Chordomas originate from malignant transformation of notochordal cells. They are typic alli located in the sacrum, 50%, clivus, 35%, and vertebrae, 15%. They may rarely be found in the mandible, maxilla, and scapula. Spheno-occipital chordomas typically affect males and females in equal incidence, and the average age ranges from 20 to 40 years. The majority of them demonstrate bone destruction and amorphous calcification. The solid components show variable but often marked contrast enhancement, and MRI may show a soap bubble appearance. Bone sclerosis is rare. The description given is that of a malignant process. Meningiomas typically affect older females and only rarely, 1%, arise from the clivus. Plasmacytomas tend to occur in an older age group, are more common in the thoracic/lumbar spine, and are often osteolytic and grossly expansile lesions. Metastasis is a possibility, although from the description given, particularly the calcification and amount of tumor extension, chordoma remains the most likely diagnosis. E. Sphenoid sinus cyst. 37. A 50-year-old woman presents with a palpable lump in her neck. Imaging demonstrates a malignant-looking mass in the thyroid gland. Which of the following findings would direct you towards a confident diagnosis? A. Complex mass with areas of necrosis. Papillary carcinoma. B. B. Calcified lymph nodes. Medullary carcinoma. Lymph node calcification accompanied by a thyroid tumor is highly suggestive of medullary carcinoma. This tumor arises from parafollicular C cells and can cause elevated calcitonin levels. The familial form of medullary carcinoma is associated with MEN2, parathyroid hyperplasia, pheochromocytoma. All four carcinomas may demonstrate calcification within the tumor and may also show various amounts of necrosis. Follicular carcinoma typically shows early hematogenous spread, and metastases to bone are almost always osteolytic. Although rare, papillary carcinoma can also spread to bone and the lungs. Approximately 75% of anaplastic carcinomas have associated regional lymphadenopathy, however, papillary, 40%, but almost 90% in children, and medullary, 50%, also show regional lymphatic spread. Refs, Dannert p. 400. A 38-year-old gentleman presents with a dull ache in his jaw. There is minor swelling over the left mandible. Plain radiographs demonstrate an expansile, multilocular, radiolucent lesion with internal septations involving the left body of the mandible. It is associated with an impacted tooth. CT shows infiltration of the adjacent soft tissues. There are no discernible foci of calcification. What is the most likely diagnosis? A. Odontogenic myxoma. B. Dentigerous. 150. Module 6 central nervous and head and neck answers. And the maxilla, 25%, and are often associated with an impacted/unerupted tooth. When in the mandible, they typically occur in the region of the molars/angle of the mandible. Typically, ameloblastomas are radiolucent lesions that contain septa or locules of variable size, which produce a honeycombed appearance. The margin is usually well defined, but when large it can produce jaw expansion with perforation of the cortex. They may infiltrate adjacent soft tissues and show local recurrence following excision. Amyloblastomas may be unicystic, but these tend to occur around the age of 20 years, and there is also a very rare malignant variety which can cause lung metastases. Odontogenic keratocysts, dentigerous cysts, odontogenic myxomas and periapical cysts are invariably unilocular. Refs, Dannert P. 18181, Granger and Allison P. 39. A middle-aged gentleman is diagnosed on imaging with suspected laryngeal carcinoma. Which of the following factors would favor a diagnosis of adenoid cystic carcinoma over squamous cell carcinoma? A. A history of long-term smoking. B. Involvement of regional neck lymph nodes. C. Invasion through laryngeal cartilage. D. Supraglottic extension. E. Propensity for nerve invasion. P. 1438. 39. E. Propensity for nerve invasion. Laryngeal adenoid cystic carcinoma accounts for approximately 1% of all malignant laryngeal tumors. CC laryngeal carcinoma 98%. Typically, there is an absent history of smoking and regional lymph nodes are hardly ever involved. 80% of them are subglottic, around the junction with the trachea, but they may spread through the entire larynx. Their characteristic feature is their propensity to invade nerves leading to paralysis. Ref. Dannert P. 376. Invasion. 40. Which of the following statements best describes the features of amyloid angiopathy? A. Solitary, peripheral hemorrhagic focus in a hypertensive elderly patient. B. Solitary, central hemorrhagic focus in a normotensive young patient. C. Multiple, peripheral hemorrhagic foci in a normotensive elderly patient. D. Multiple, central hemorrhagic foci in a normotensive elderly patient. E. Multiple, central hemorrhagic foci in a hypertensive young patient. C. Multiple, peripheral hemorrhagic foci in a normotensive elderly patient. Multiple peripheral hemorrhages, corticomedullary junction, in normotensive elderly patients are suggestive of amyloid angiopathy. Hypertensive hemorrhage tends to occur centrally around the basal ganglia, putamen, external capsule, thalamus and pons. Ref. Dannert P. 233. A 7-year-old boy presents with pain in his neck. His mother thinks she can feel a lump. Ultrasound shows a thick-walled cyst with internal echoes. It has a paramedian location within the strap muscles. MRI shows a heterogeneous cystic mass measuring 3 cm in diameter. It demonstrates high signal on T1 and contains areas of low signal on T2. There is marked enhancement of the wall after administration of gadolinium. What is the most likely diagnosis? A. Infected thyroglossal duct cyst. B. Fibroma. C. Ref. Dannert P. 233. 41a. Infected thyroglossal duct cysts. Thyroglossal duct cysts arise from the remnants of the embryonic thyroglossal duct and account for up to 70% of congenital neck masses in children. Typically, children present with a non-tender mass that elevates on swallowing. If infected, there may be pain, local tenderness and recent increased growth. Most are midline, although they become more paramedian below the level of the hyoid. Approximately 20% are suprahyoid, 15% occur at the level of the hyoid, and 65% are infrahyoid. Generally they are thin-walled cysts and show typical cystic imaging characteristics. If infected or if the cyst has hemorrhaged, high signal may be seen on T1, and low signal may be present on T2, weighted Mr. images. Hemorrhage and infection may also cause thickening and marked enhancement of the wall. Ref. Barkovich P. 556. E. Lymphangioma. 42. A 3-week-old girl is investigated for a right orbital mass. CT shows a diffuse, poorly marginate mass in the superior temporal quadrant of the orbit. It is separate from the globe and the mass shows diffuse enhancement post-contrast injection. On MRI, the mass is hypointense to fat on T1 but hyperintense on T2. On both sequences, low-signal curvilinear foci are seen within it. What is the most likely diagnosis? A. Lymphangioma. B. Rhabdomyosarcoma. C. Cavernous hemangioma. D. Retinoblastoma. E. Capillary hemangioma. 43. An 8-year-old Ref. Barkovich P. 556. 42. E. Capillary hemangioma. Capillary hemangiomas are the most common vascular orbital masses in children. They typically present at birth or shortly after. CT shows a diffuse, usually poorly marginate mass which shows diffuse contrast enhancement. On MRI the mass is hypointense to fat on T1, and on T2 it is hyperintense to muscle and fat but hypointense compared to fluid. Curvilinear flow voids representing blood vessels are typical within the mass. They tend to grow rapidly over the first 6 months of life, stop growing during the second year, and then slowly involute over subsequent years. Ref. Barkovich P. E. Capillary hemangioma. 43. An 8-year-old boy with skin hyperpigmentation presents with deteriorating vision and hearing loss. CT shows large symmetric low-density lesions in the parietal occipital white matter. T2. Weighted MR imaging demonstrates confluent symmetric hyperintensity within the parietal occipital white matter extending. 43. D. Adrenoleukodystrophy, ALD. ALD is an inherited metabolic disorder characterized by progressive demyelination of cerebral white matter. It is commonly X-linked recessive in boys present between the ages of 3. E. Autoimmune vasculitis. 44. A 49-year-old woman with AIDS presents with increasing headache. T1. Weighted MR imaging demonstrates a hypointense lesion in the periventricular white matter of the left parietal lobe. The lesion is hypointense on FLAIR sequencing and is seen to cross the splenium of the corpus callosum. There is peripheral enhancement post-contrast injection. The most likely diagnosis is A. Toxoplasmosis, B. 44. C. Primary CNS lymphoma, PCNSL. PCNSL is the second most common cause of a CNS mass in patients with AIDS, behind toxoplasmosis. Typical features include periventricular location with subependymal spread and crossing of the corpus callosum. Non-contrast CT may show a hyperdense lesion due to dense cellularity. For this reason it may also be hypointense on T2/FLAIR. There is often a paucity of edema and frequent ring enhancement due to central necrosis. Note this is in contrast with the solid homogeneous enhancement seen with lymphoma in the immunocompetent patient. Cryptococcosis is the most common cause of fungal infection in AIDS patients. CT is frequently normal and MRI shows low T1 and high T2 signal intensities without enhancement in the lenticulostriate region. Progressive multifocal leukoencephalopathy typically shows bilateral white matter lesions in the periventricular region, centrum semiovale or subcortical white matter, which are hypointense on T1 and hyperintense on T2/FLAIR. There is typically no edema nor mass effect and no contrast enhancement. Refs, Dannert P. 265. 45. A homeless adult male is admitted with a change in mental state and a metabolic abnormality. CT shows a focus of reduced attenuation in the pons. On MRI the focus is hypointense on T1 and hyperintense on T2. There is restricted diffusion on diffusion-weighted imaging, and there is no enhancement post-contrast. What is the most likely diagnosis? A. Brainstem glioma, B. Metastasis, C. Infarction, D. Tuberculosis, E. Osmotic myelinolysis. 45. E. Osmotic myelinolysis. Osmotic myelinolysis is also referred to as central pontine myelinolysis or osmotic demyelination syndrome. It is classically seen in an alcoholic, hypoatremic patient in which rapid correction of sodium releases myelinotoxic compounds leading to destruction of myelin sheaths. The pons is the commonest site, although extrapontine areas such as basal ganglia, cerebellar white matter, and thalami may also be involved. Some patients completely recover, but the 6-month survival rate is only 5–10%. Brainstem gliomas tend to occur in children and young adults. Typically the brainstem is asymmetrically expanded with displacement/compression of adjacent cisterns. Local vessels may also be displaced. Enhancement is variable. Pontine/medulla infarcts account for approximately 2% of all brain infarcts. They may show similar appearances to those described in the question, but may also demonstrate enhancement. One would expect enhancement with metastasis. 152. Module 6 Central nervous and head and D. Tuberculosis, E. Osmotic myelinolysis. 46. A 33-year-old male with no significant past medical history presents with headache, drowsiness, and confusion. CT shows a hypodense lesion with a smooth regular wall centered over the left lentiform nucleus. There is surrounding edema and mass effect with effacement of the ipsilateral sylvian fissure. On T2, weighted MR imaging, the lesion is hyperintense and is surrounded by a hypointense rim and hyperintense edema. There is peripheral enhancement post-contrast injection, and diffusion-weighted imaging demonstrates restricted diffusion within the lesion. What is the most likely diagnosis? A. Glioblastoma multiforme, B. Pyogenic abscess, C. 46. B. Pyogenic abscess. The differential diagnosis for a solitary ring-enhancing lesion of the brain includes magical DR, metastasis, abscess, glioma/glioblastoma multiforme, infarction, contusion, AIDS, toxoplasmosis, lymphoma, often AIDS-related, demyelinating disease, resolving hematoma/radiation necrosis. Classically, abscesses are located at the corticomedullary junction in the frontal and temporal lobes. The most common E. Metastasis. 47. A 15-year-old girl presents with suspected optic neuritis. Post-contrast T1, weighted imaging shows enhancement and mild enlargement of the right optic nerve. Several months later the girl represents with symptoms of myelitis. Sagittal T2, weighted imaging of the spine demonstrates intramedullary T2 hyperintensity and cortex expansine extending from C1 to T1. At the time of the initial and subsequent presentations, brain imaging was normal. What is the most likely diagnosis? A. Multiple sclerosis. B. Sarcoidosis. C. Divik syndrome. D. Neurofibromatosis. E. Ependymoma. (47) C. Divik syndrome. DS. Divik syndrome. Neuromyelitis optica. Optica, NMO, is a severe demyelinating syndrome characterized by optic neuritis and acute myelitis. Myelitis. There is substantial evidence that DS is distinct from multiple sclerosis, MS. DS may spare the brain, the spinal lesions are much larger than in MS, and the serum autoantibody NMOIgG is greater than 90% specific for DS patients, and is not detected in classical MS patients. The proposed diagnostic criteria for Divik syndrome are optic neuritis and acute myelitis plus at least 2 of 3 supporting criteria. 1. Contiguous spinal cord MRI lesion extending over greater than or equal to 3 vertebral segments. 2. Brain MRI not meeting diagnostic criteria for multiple sclerosis. 3. NMOIgG seropositive status. Ref. Wingerhoop DM ETAL revised diagnostic criteria. (48) A 5-year-old boy presents with visual fixation. The ophthalmologist suspects optic nerve hypoplasia. Brain CT confirms optic nerve hypoplasia, an absent septum pellucidum, and a third cerebral abnormality. What is the third abnormality likely to be? A. Schizencephaly. B. Cortical dysplasia. C. Polymicrogyria. D. Agenesis of the corpus callosum. E. Type 2 Chiari malformation. 49. A 29-year 48. A. Schizencephaly. The combination of absent septum pellucidum and optic nerve hypoplasia is indicative of septo-optic dysplasia (SOD. Most patients present in infancy with visual disturbance, seizures, or endocrine abnormalities, pituitary dysfunction is seen in approximately 50% of cases. Additional abnormalities are often present with schizencephaly being the most common, 50%. Ref. 49. A 29-year-old woman undergoes a brain CT for severe worsening headache. She is 20 weeks pregnant. No acute pathology is demonstrated. However, an incidental finding of a small right parietal arteriovenous malformation is noted. This is confirmed on 137. Module 6 central nervous and head and neck. Subsequent MRI. You are asked to counsel the patient. What is the most appropriate advice? A. Normally the risk of hemorrhage is 2-3. 49. D. Normally the risk of hemorrhage is 2-3% per year, but there is no significant increase in risk during pregnancy. Recommend review after delivery to discuss treatment options. Arteriovenous malformations, AVMs, are congenital lesions consisting of multiple arteries and veins connecting as a fistula without an intervening normal capillary bed. The majority. 153. Module 6 central nervous and head and neck answers are solitary lesions except when associated with hereditary hemorrhagic telangiectasia. Approximately 90% occur in the supratentorial region, parietal, frontal, temporal. About half of AVMs present with hemorrhage, intracerebral, subarachnoid, intraventricular, approximately 25% present with focal or generalized seizures, and 15% present with headache. The overall risk of hemorrhage for an unruptured AVM is about 2-3% per year. This increases to 6-17% in the first year following first hemorrhage, and then decreases to a baseline level by the third year. Following a second hemorrhage, the annual risk of rebleed rises to 25% in the following year. An approximate lifetime risk for patients with previously unruptured AVMs can be calculated as 105 minus the patient's age in years. Current data suggests that pregnancy does not increase the risk of an AVM hemorrhage, however when possible AVMs should be treated before pregnancy. If the lesion is noted during pregnancy and there is no hemorrhage, treatment risks should be considered higher than the risk of hemorrhage, and treatment may be deferred until after pregnancy. Ref. Brown RD JR ETA 50. A 36-year-old female presents following a tonic-clonic seizure. Over the preceding months she had suffered with progressive, severe headaches. Contrast-enhanced CT brain shows lateral displacement of the internal capsules by enlarged thalami, but no abnormal enhancement. T2, weighted MRI demonstrates a diffuse, contiguous area of hyperintensity involving the thalami, caudate and lentiform nuclei, the splenium of the corpus callosum, and the periventricular white matter. There is only minimal mass effect. T1, weighted gadolinium imaging shows no enhancement. What is the most likely diagnosis? A. Multiple sclerosis. B. Gliomatoses cerebri. C. Viral 50. B. Gliomatoses cerebri. GC. GC is a diffusely infiltrative glioma that may be present with or without a dominant mass. It must, however, involve 2 or more lobes and usually involves contiguous areas. It affects all age groups and can be of varying histological grade. Presentation may be enigmatic as the normal cerebral architecture is usually preserved. Alternatively, patients present with seizures, headache, and personality disorders. Prognosis is poor. MRI findings include diffuse T2 and proton density, hyperintensity throughout the white matter that usually extends to involve the deep gray nuclei with enlargement of cerebral structures. It is often bilateral and symmetric with minor mass effect and absence of necrosis. The differential diagnosis of symmetric white matter lesions includes microvascular change, encephalitis, demyelinating disease, vasculitis, and leukoencephalopathy. GC is the most likely diagnosis in this scenario, as there is involvement of the corpus callosum and the pattern is infiltrative with enlargement of the thalami, cerebral structures. (51) A neurologist requests an MRI scan of a patient with long-standing temporal lobe epilepsy. He suspects mesial temporal sclerosis. What imaging plane would you pay particular attention to, and what would you expect to find in this condition? A. Axial plane demonstrating volume loss and reduced signal intensity of the parahippocampal gyrus on T2, weighted imaging. B. Cornal plane demonstrating volume loss and increased signal intensity of the hippocampus on T1, weighted imaging. C. Cornal plane demonstrating volume loss and increased signal intensity of the parahippocampal gyrus on T2, weighted imaging. D. Axial plane demonstrating volume loss and reduced signal intensity of the hippocampus on T1, weighted imaging. E. Cornal plane demonstrating volume loss and increased signal intensity of the hippocampus on T2, weighted imaging. 52. A male patient presents with severe back pain following surgery. 53. 51. E. Coronal plane demonstrating volume loss and increased signal intensity of the hippocampus on T2. Weighted imaging mesiotemporal sclerosis. Hippocampal sclerosis is the most common lesion associated with temporal lobe epilepsy. Acquisition in the coronal plane is mandatory for its detection. MRI typically shows volume loss and increased signal on T2. Weighted imaging. Ref. Granger and Allison P. 1000. 52. A male patient presents with severe back pain following surgery 7 months previously. MRI shows extensive clumping of roots of the cauda equina to the right of the midline, suggesting an intrathecal mass. There is no enhancement post-gadolinium administration. What is the most likely diagnosis? 138. Module 6 central nervous and head and neck. A. Intrathecal metastases. B. Nerve root sheath tumor. C. Arachnoiditis. D. Extradural hematoma. E. Prolapsed intervertebral disc. 53. 52. C. Arachnoiditis. Arachnoiditis is an intrathecal inflammatory reaction which usually results from iatrogenic injury. Previously, it was associated with the injection of contrast agents during myelography. Now, it is most commonly seen following lumbar surgery. Intradural infections, TB, fungal, parasitic, are rare causes. Radiologically, arachnoiditis appears as nerve root adhesion. Commonly the nerves are clumped together simulating a solid mass, although the nerves may also adhere to the dura. 154. Module 6 central nervous and head and neck answers. Giving the appearance of an empty thecal sac. In severe cases, the thecal sac may become loculated and compartmentalized. Clumped nerve roots suggest arachnoiditis, and the lack of enhancement makes tumors unlikely. Ref. Granger and Allison P. 1385. D. Extradural hematoma. E. Prolapsed intervertebral disc. 53. You are asked to provide an opinion on skull and facial radiographs of an infant. The history provided is recent fall, known dwarfism. The radiographs show brachycephaly, widened sutures, relatively large sella, Wormian bones, delayed dentition, decreased pneumatization of the paranasal sinuses, and hypertelorism. No fracture is demonstrated. What is the most likely diagnosis? A. Cleidocranial dysostosis. B. Hypophosphatasia. C. Hypothyroidism. D. Achondroplasia. E. Pycnodysostosis. 53. C. Hypothyroidism. Many of the features listed may be seen in any of the differential conditions provided. However, large sella and hypertelorism favor a diagnosis of hypothyroidism. Refs. Dennert pages 177-178. Granger and Allison. E. Pycnodysostosis. 54. A 3-year-old girl undergoes further investigation for refractory seizures. Contrast-enhanced T1. T1. Weighted imaging shows diffuse P-all enhancement of variable thickness over the parieto-occipital region of the right cerebral hemisphere. There is atrophy of the underlying cerebrum, and the right choroid plexus is enlarged. Several hypointense foci are seen within the gyri and adjacent white matter. There is also bilateral well-defined orbital choroidal enhancement. T2. Weighted imaging demonstrates prominent superficial cortical veins. What is the most likely diagnosis? A. Klippel-Trenaunay syndrome. B. Sturge-Weber syndrome. C. Wyburn-Mason syndrome. D. Neurofibrosis. Refs. Dennert pages 177-178. Granger and Allison P. 1707. 54. B. Sturge-Weber syndrome. Sturge-Weber syndrome is a congenital disease characterized by capillary venous angiomas involving the face, port wine stain, usually ophthalmic division of trigeminal nerve, choroidal VI and leptomeninges. Clinical manifestations include focal seizures, 80% in the first year of life, developmental delay, hemiparesis, and homonymous hemianopia. Seizures typically become refractory to medication. Leptomeningeal angiomas are confined to the pia mater and occur primarily within the parieto-occipital region. There is cortical hemiatrophy beneath the angioma due to local anoxia, and usually after the age of 2 years there is cortical calcification manifesting as low signal intensity on T1 post-contrast images. Other findings include enlargement of the ipsilateral choroid plexus, dilatation of the transparenchymal veins that communicate between the superficial and deep cerebral venous systems, and orbital choroidal hemangiomas. Refs. Dennert P. 326. 55. A 35-year-old female presents with worsening headache and facial droop. Her chest radiograph is abnormal. Non-contrast enhanced CT brain is unremarkable. MRI demonstrates leptomeningeal thickening and enhancement, particularly around the basal cisterns. Enhancement extends along the right 7th cranial nerve and along the optic nerves. There are several small superficial parenchymal enhancing lesions found bordering the basal cisterns. What is the most likely diagnosis? A. Sarcoidosis. B. Tuberculosis. Meningitis. C. Carcinoma. 2. Meningitis. D. Lymphoma. E. Behçet syndrome. 56. 55. A. Sarcoidosis. Neurologic manifestations of sarcoidosis occur in 5% of patients. In over 80% of established cases, the chest radiograph is abnormal. Sarcoidosis can involve any part of the nervous system, however it has a predilection for the leptomeninges, arachnoid, and pia mater. The most common sites for the disease are the basal meninges and the basal midline structures including the hypothalamus, optic chiasm, and pituitary. Sarcoidosis also commonly involves the cranial nerves, which may reveal abnormal enhancement on contrast-enhanced T1 weighted imaging. The facial nerve is the most common cranial nerve-involved clinic ally, whereas radiologically, the optic nerves are most commonly abnormal. Dural thickening/dural-based masses may also be present. Parenchymal sarcoidosis can be seen, as enhancing granulomas usually located superficially in the brain parenchyma bordering the basal cisterns. Non-enhancing lesions in the periventricular white matter and brainstem are common. Hydrocephalus occurs in approximately 10% of cases. Ref. Granger and Allison P. 1338. Vagal as ETAL radiological man. E. Behçet syndrome. 56. A 60-year-old man presents with back pain and progressive paraparesis. T1 weighted MR imaging shows loss of T9, T10 disc space with hypointense signal involving multiple contiguous vertebral bodies. Skip involvement of T3 and L1 vertebral bodies is evident. T2 weighted imaging shows a large paraspinal and prevertebral mass. An anterior epidural collection is seen compressing the cord. On post-contrast T1 weighted imaging the vertebral bodies show inhomogeneous enhancement and 139. Module 6 central nervous and head and neck. The paraspinal mass shows peripheral enhancement with central necrosis. What is the most likely cause? A. Pyogenic infection. B. Lymphoma. C. Sarcoidosis. D. Tuberculosis. E. 56. D. Tuberculosis. The vertebral column is the most common site of osseous involvement of tuberculosis, TB, usually as the result of hematogenous spread from pulmonary involvement. The lower thoracic and upper lumbar vertebrae are the most frequently affected. It can be difficult to differentiate between pyogenic E. Metastases. 57. A 4-month-old male undergoes investigation for microcephaly and hearing loss. Unenhanced CT brain shows several periventricular subependymal cysts and multiple coarse periventricular and parenchymal white matter calcifications. There is diffuse hypoplasia of the cerebellum. What is the most likely diagnosis? A. Tuberous sclerosis. B. Sturge-Weber syndrome. C. Cytomegalovirus infection. D. Venous sinus thrombosis. E. Congenital rubella. 58. A 40-year-old 57. C. Cytomegalovirus infection. This is the most common intrauterine infection and the leading cause of brain disease and hearing loss in children. Typical imaging findings include periventricular subependymal cysts representing focal areas of necrosis and glial reaction, periventricular post-inflammatory calcifications, scattered calcifications in basal ganglia, and brain parenchyma, microcephaly due to disturbance of cell proliferation and hypoplasia of the cerebellum. There may also be lissencephaly, cortical dysplasia, polymicrogyria, and schizencephaly due to disturbed neuronal migration. Ref. Dannert p. 217. Old unkempt male is admitted with disorientation and ataxia. Flare T2 and diffusion-weighted MR imaging reveal abnormal high signal in both medial thalami, the hypothalamus, and periaqueductal gray matter. There is atrophy of the right mammillary body. What is the most likely diagnosis? A. Lymphoma. B. Viral encephalitis. C. Creutzfeldt-Jakob disease. D. Vernickies Encephalopathy. E. Venous thrombosis. 58. D. Vernickies Encephalopathy. We refers to an acute or subacute syndrome characterized by disorientation, gaze paralysis, ataxia, and nystagmus. It invariably occurs in chronic alcoholics, but it is caused by thiamine deficiency. Involvement of the medial thalami is characteristic, and typically the mammillary bodies, periaqueductal gray matter, and hypothalamus are also involved. In the acute stages of the disease, hemorrhage, necrosis, and edema are encountered, whereas in the latter stages these regions tend to atrophy, particularly the mammillary bodies. 59. A 48-year-old female presents with tinnitus. CT shows a soft tissue mass in the region of the hypotympanum. There is irregular bone demineralization in the region of the carotid canal and jugular foramen, making their margins irregular and partially indistinct. On proton density MR imaging, the mass has mixed hyper and hypointensity signal. The tumor shows strong enhancement after gadolinium administration. What is the most likely diagnosis? A. Glomus tympanicum tumor. B. Glomus jugulare tumor. C. Carotid body tumor. D. Glomus vagal tumor. E. Cholesteatoma. 60. A 62-year-old female 59. B. Glomus jugulare tumor. All of the tumors listed in the differential, apart from cholesteatoma, are paragangliomas. They grow slowly and rarely metastasize. Glomus jugulare tumors originate from the adventitia of the jugular vein. CT demonstrates a soft tissue mass in the region of the jugular bulb/hypotympanum/middle ear space. Local bone destruction is common, PA articularly of the jugular plate, or the lateral portion of the carotid-jugular spine. A unique salt and pepper pattern of hyper and hypointensity on T1 and T2 weighted images is also seen. This represents multiple small tumor vessels. They are highly vascular lesions, usually deriving a blood supply from branches of the external carotid artery. Ref. Salmon curtain p. 1306. 60. D. 70%. D. Glomus vagal tumor. E. Cholesteatoma. 60. A 62-year-old female presents with symptoms of amaurosis fugax. Ultrasound Doppler of her right internal carotid artery reveals a peak systolic velocity of 2.4 m/s. What is the likely degree of stenosis? A. 0.24%. B. 25.49%. C. 50.69%. D. 70%. E. 90%.